All right, guys, we're going to go ahead and get started with our CPC for today. Thank you so much for joining us. Disclosure slide to start. So for our case today, we have a 42-year-old man, past medical history of anxiety and GERD, presenting with chest pain and shortness of breath. And joining us today is Dr. Husaini. And
good afternoon, everyone. Thank you for coming. I'm glad we have, I see a single cardiology fellow that I can call on, which is good. So Josh, you are up next. So get ready, finish your lunch. I'll need a lot of help, and I'm glad to see some faculty and, of course, all of you. And so we're going to get started.
Like returning back to our one-liner, I will say I did slip in shortness of breath because I did feel kind of bad that I only said chest pain and that was all. So kind of going into some of the presenting. So initially, your patient was actually at an outside hospital, coming in because he had an acute onset of pleuritic chest pain and shortness of breath, said it started the night before, and he kind of went a couple hours later to the outside hospital. Is saying that the pain is more so left-sided, does not radiate, actually improves when he leans forward, was in his usual state of health prior, kind of nothing out of the ordinary had happened before those symptoms, and then denies dizziness, lightheadedness, syncope, palpitations, orthopnea, PND, swelling, illness, or preceding trauma. So does that provide any?
I'm trying not to anchor, but this sounds like a stem of a board question. And so can I ask more questions now, or should we just go on?
Yeah.
So so it says acute onset of chest pain. Were there any kind of constitutional symptoms or other things preceding this?
There were not.
Not documented or not asked?
Asked, and the patient says no.
Okay.
And also not documented, I guess.
Okay. So this is, let's just pause. Let's just keep going.
Okay.
Yeah. Because I was going to see what else is next. So.
Okay. All right. And then anything, I guess at this point, if you could ask like anything at all, because the next slide will give us kind of a little bit more of a direction as well.
So from a history, not getting an EKG or anything yet?
Yeah.
From a history.
Yeah. Just from a history standpoint. I'm sorry to do this to you. I'm sorry to do this.
We do so much thing concurrently. This is kind of hard.
He says no recent illnesses, had been in his usual state of health immediately leading up to when the symptoms started. No substance abuse.
And what does this person do for work? Or
he was formerly doing construction and was a coal miner, and then had quit a couple months ago.
Do we know why he quit a couple months ago?
Not sure 100% why he decided to quit.
Was it health related?
Was it health related? I think it did kind of coincide with some of, yeah.
So just to recap, acute onset pleuritic chest pain last night was something lingering a few months prior.
Yeah.
That basically caused him to get so symptomatic that he is no longer working a manual labor job.
Yeah.
Thank you.
Okay. Any recent travel? The patient does not note any travel recently.
Kind of like crowdsourcing.
I know, this is great.
Nice. We should keep doing this.
Please continue.
Oh, you definitely can.
You
definitely are allowed to. Well, we'll not say no to free help.
Yeah.
Maybe getting some of our non-cardiology colleagues. You guys see this a lot more before you guys call us. What questions would you guys ask? I see some of you guys. I'm looking right at you.
Okay, so we can help fill in the blanks for Dr. Husaini a little bit more. So as he kind of alluded to, putting the pieces together, he has this acute onset of a symptom, but then if you're kind of thinking back, was there anything kind of prior symptom-wise? And the patient actually does note that he had similar symptoms in the past. So you get some of your records back and you find that he's had a history of recurrent pericarditis and has been seen multiple times at outside hospitals before. So the first time he ever felt this way or something similar was April of 2024. For reference, you're seeing him in October of 2024. So it's about a 6-month span. So at that time, you're able to access the records and you are able to corroborate that he was diagnosed at that time with pericarditis. They actually did see a large pericardial effusion associated with it. And at that point, they actually needed to intervene. So we got a pericardiocentesis then due to concern for an impending tamponade physiology. Fluid studies were sent. The path was negative, including fungal and culture, and then cytology was negative as well. And then at that first initial contact, he was discharged with a course of colchicine and naproxen. Then it recurred again in July. At that time, they were describing a small pericardial effusion, didn't need to do other interventions. He remained stable, and then they discharged him again with a course of colchicine and indomethacin. And then moving on to September, he did have another instance of chest pain. It was concerning for recurrent pericarditis then, but unfortunately the patient decided not to stay. I think he started to feel a little bit better, so he left. And then he was given colchicine and prednisone and was told to follow up outpatient. So hopefully that's a lot more information than.
It's very helpful. And actually kind of ironic because Prashant just asked me to do pericardial section for the cardiology fellows in like a few weeks. So I'm like, a little ironic here. But during any of these visits, did you have any inflammatory markers with this pericarditis, or were they checked, or kind of what was the status of that?
Yeah, like the ESR and CRP. Yeah. They were checked during each of those time periods, and I want to say that all of them were elevated.
All of them were elevated. Yeah. Okay. Anything? I'm assuming he didn't have any healthcare between visits to check for improvement, or we don't know?
Between April and July, he did have one outpatient visit, and he was actually like considered stable at that time. Mm-hmm. And then unfortunately was like admitted pretty quickly after that. And then between July and September, I think he also maybe had like an outpatient family medicine visit. Okay. But then unfortunately hadn't returned.
Okay.
Yeah.
And then any heart failure symptoms or fluid overload symptoms kind of in this progression that he's been having?
Not that he was noting when you're seeing him in the beginning of October.
Beginning of October. Okay.
Yes.
Yeah.
Mm-hmm. Yeah, that's a great question. So the question was, did the patient's symptoms ever resolve kind of within these different periods? And they actually did. So April, he was on this course of colchicine and naproxen. It did kind of get better. And then I think the course of the naproxen, it had ended 2 weeks before July when he had to return. And then he was on both the colchicine and endomethacin. He had been doing better until September, and then it kind of just recurred again.
And was he eating tapering doses, or was he kind of like just a 2 to 3 month course, and then they kind of stopped it?
The colchicine, they wanted to continue like over month spans at a time. Okay. I know the naproxen course had ended before July. Okay. Then endomethacin, I want to say had ended right before September, okay. But I think the colchicine had stayed on the whole time.
And then back to this present illness. So you said subacute onset or acute onset of symptoms the night before. Mm-hmm. Any exertional symptoms in the weeks before this? Going through like does he exercise? Does he just sit on the couch all day? What does he kind of do?
Yeah, I don't think that he was very like physically active, but he didn't report that he felt like physically unable to walk or kind of do his like daily normal activities.
Okay. Sounds like he needs a CPAP, but
maybe. Okay. So we can, of course, continue to add on more questions as we move on, but just to kind of round them all out. So medical history, which we kind of established already, surgical history, had a cholecystectomy before, nothing notable on his family medical history, no allergies, medications, kind of pretty benign stuff. And then the colchicine he had stayed on, and then the prednisone taper he had finished kind of right before you were seeing him now. And then social history wise, had smoked cigarettes before, currently does vape. I will say his tobacco history, I think he had like a 20+ year history, so it's pretty significant. And then we had established his occupation as a coal miner. Had been, I want to say like over 10 years he had worked as a coal miner, but is not doing that currently.
Can you go back to the last slide real quick?
Yes.
And then do we know, so he's still on the prednisone taper when he comes in?
Yeah.
Because it's the month before and it's just, okay.
Yeah, exactly.
Okay. So I don't, nothing further I'm thinking of right now. So
okay.
Keep going.
Okay. So now we'll just get to the review of systems. So anything in particular that you would want to like highlight or pinpoint that we maybe hadn't covered with him yet?
I think the main thing is kind of just the constitutional symptoms, fevers, chills, other kind of infection type things. Yeah. I mean, the history is pretty classic for recurrent pericarditis again. Mm-hmm. And again, that's probably going to be the common thing. But I mean, a fourth recurrence of something, because there's something else going on with it. Mm-hmm. I'm not sure. This is one of those things where you're trying not to anchor too early on. Sure. There's just kind of getting information and kind of seeing where sometimes just time can be the create has been a factor of just seeing as they present and seeing kind of how things evolve over the next couple hours.
Yeah. Okay. So we kind of got to the additional thoughts part. And then moving on to the physical exam for him. Oh, sorry. And I might have gone through the ROS pretty quickly, but I think it was kind of things that we already know.
What you would expect.
Yeah. And then notable on his exam. So reportedly a distant sounding S1 and S2, and then decreased breath sounds predominantly at the bases bilaterally of the lungs.
And do we have a pulsus paradoxus by chance?
Not documented.
Not documented. Do we know his baseline blood pressure and baseline heart rate?
Yeah, his baseline blood pressure, it was pretty normotensive actually. So I'd say the systolic was closer to like the 120s over 80s. Yeah.
And baseline heart rate?
Baseline heart rate was maybe a little bit lower. So this is a little bit more
Higher.
tachycardic for him.
Okay.
Yeah.
And he's 42, is that
Mhm.
correct? Okay. So again, normal heart rate, but not normal heart rate. So
Yeah.
And SO2 is 95%. You said he smoked for 10
20
years.
Yeah,
so?
20 years.
I'm assuming he's never had PFTs before all this.
Any PFTs before? No.
Okay.
Yeah. Not really had a lot of like contact with the medical system prior to April.
I know the type, so yes.
What's that?
Said I know the type.
You
No
know the
phenotype,
type.
So yeah.
Okay. So now we'll be able to provide you hopefully with a little bit more objective data. So starting with our menu of choices here, I know probably what your go-to would be. But...
Let's go non-traditional and get a chest X-ray first.
Okay. Yeah, I do have a chest X-ray. I'm sorry that it actually did not upload correctly when I tried on the slide, but I can show it to you.
Wow. I'm glad I picked that one first. Can you show that for everyone?
Yeah, I'm not sure.
I won't pass your phone around.
So, yes. So for the read on the chest X-ray, they're describing a moderate left and small right pleural effusion with underlying atelectasis, no pulmonary edema or pneumothorax. Cardiac silhouette is obscured but enlarged, corresponding to extensive pericardial and subpericardial soft tissue.
So badness. Hey, an EKG, please.
Yes.
Ooh. Who wants to help me with what they see here? So clearly sinus tachycardia, right? The thing will kind of goes into, well, actually I'm not going to jump ahead. So sinus tachycardia, our axis is normal. We can see in the lateral leads or some kind of SC segment elevation with depressions kind of precordially and kind of inferiorly. Do you think is this, in a different clinical context, is this acute coronary syndrome or is this kind of localized pericarditis? And the AVR is kind of hard to see that can help with that sometimes, but when I look closer, it does look like there is PR elevation and SC depression, and everything else is kind of reciprocal from there, which again, in the clinical context and everything else is more consistent with pericarditis.
Okay, awesome. And then just to kind of include as part of just the initial cardiac eval that you would have done. So troponins, when he first came in, peaked to 83 and then downtrended. NT-proBNP was like the 5,000 to 6,000 range. And then we don't have like baseline for that. And then TTE, I realized that it would have been maybe more helpful if you got the images, so I apologize about that. But we do have your read if you want to take a moment.
Yeah, so I mean, the first thing is like, well, before we get the echo, right? The troponins are positive in technicality. So is this myopericarditis with ECP that's kind of mentioned there. NT-proBNP is elevated, which obviously makes sense with the chest X-ray that we described and that we saw. But the main thing I think that is kind of described here is that there's a thickened pericardial space with a loculated effusion, then anus paradoxis is present. And so I know we have a lot of sonographers here, and does someone want to kind of fill in what anus paradoxis is? So I think we had to talk about this recently, if I remember correctly, or did I hallucinate that? Where's Crystal? I thought I saw Crystal. There we are. Didn't we have a talk about this recently, or am I just hallucinating that? You don't recall that talk? So I thought we did. But the idea, right, is that we measure the mitral annulus. We look at the one closer to the septum, which is technically a little bit more unable to move because it's next to the septum, and one at the lateral wall, which is more free. And so we measured the velocity that the mitral annulus is moving at both of these points. And normally the lateral mitral annulus is more free, should move faster than the septum. Now, if you think of constriction, you have a sac that's tightening up on the heart. That lateral segment can't move as fast or as well. And so what we see is that that the mitral annulus lateral side is slower relative to the septum. And so we look at the E prime velocities, what it's called, and they're reversed. And because we like Latin, we call it annulus paradoxus or reversus, kind of similar concept. So.
And is any of this, surprising so far? Or does this kind of correlate with the clinical picture we're seeing?
So far it correlates with the clinical picture, but the way you say that, I'm actually getting a little bit worried now. But the key thing to remember is that anytime someone had a pericardial effusion that then gets tapped, right, there's a really low percentage that has recurrent disease. And then of those, they can get effusive constrictive pericarditis, which often might not have a huge pericardial fluid, huge pericardial effusion, but they can get kind of tamponade physiology without having a lot of stuff there. And that's kind of the biggest thing about effusive constrictive pericarditis. It's kind of that mix of like a restrictive cardiomyopathy with tamponade, but it doesn't really look like either. It's kind of a middle ground of things.
Mm-hmm. Okay, so that was kind of our initial cardiology workup that we did.
So can we do initial labs?
Yes. Okay.
So I'm assuming, all right, so the diff is normal with that white cat, okay. And they're still taking prednisone technically?
They were back on colchicine and endomethacin on your service, or I guess like
Okay.
here at Barnes. So not on steroids.
So I guess, okay, so because I was thinking like, well, is the differentials normal? Does that mean they weren't taking their prednisone? Or is this like going far?
Oh, I see what you're saying.
Yeah.
From what I understand, they were actually had completed the course.
Oh, okay.
Presumably,
Okay.
but yeah.
So pretty benign labs.
Yes, it is.
Can we do, there's a lot of room and infectious stuff. Can we do that?
Sure. And then when you're thinking of infectious stuff, so I think you had mentioned like a tap at some point. So you want to tap the huge pleural effusion that only you and I were able to see. I'm sorry that it didn't get uploaded. But is there anything specifically when you're kind of thinking about causes, potentially the pericarditis, that you'd want for the labs?
It's a good question. And I think so the main thing is kind of back to its history, right, is the coal mine exposure, right? And there's just something there, some like from a fungal etiology, is that going to be causing something that is just there and it's kind of come out now that he's had prednisone and colchicine and some kind of immunosuppressive thing. So that's kind of the first thing that comes to mind. And I wish I had an ID colleague here to help with that. But this is where the consult services are so helpful.
Yeah.
But I'd probably start there and probably curbside someone and figure out what else I need to do at that point.
Yeah, and that approach matches the approach that the team took. So incidentally, he was like rhinovirus positive for whatever reason, but he actually wasn't really symptomatic with it. Although retrospectively, if he was a little more short of breath, maybe it precipitated his symptoms a little more. But Hep panel is negative, HIV negative, blood culture's negative. And then we do have our pleural fluid studies. I think he got it a couple days into the admission. So highlighting the RBC count and then highlighting the protein and LDH because it kind of helped us work up, exudative versus transudative.
I haven't thought about the lights criteria since I was a resident. And so I'm assuming the red blood cells is just traumatic tap, I'm assuming. And protein seems high relative to serum. LDH is also really high relative to serum. So I'm assuming that's exudative?
Yes,
okay.
yes, exudative. And then the cytology was sent and it was negative, actually.
Okay.
Yeah.
So interesting. Let's get some more information.
Let's see. And then just because you had mentioned, potentially expanding the more general infectious workup with maybe some fungal studies, that was done. So any predictions, any vibes you're getting?
Oh my God.
If this is a fungal.
This is when I use open evidence and up to date and be like, what do I need to remember to
Yeah.
do all this other stuff. So this is when I definitely would phone a friend. So
It's okay. We would ask the med student on the service to talk about
that's
it on our
fair.
rounds,
Do
probably.
we have any med students here? I don't know actually, but yeah.
Yeah. So we did all those things and turns out that it was negative. So we breathed a sigh of relief that our fungal pathologies were negative. But given the region and everything, of course, you always kind of keep it on the differential there. Okay, so we're moving right along. So we did our labs, we did our infectious, we did the EKG, looked at a chest x-ray. So what's left is kind of urine
Urine.
studies.
Let's do urine. Yeah, I'm kind of curious
Okay.
what this might show.
Okay. Not really groundbreaking with the urine studies.
Okay.
Yeah.
I like it.
Okay. So what we're kind of left with is the other big categories. So
Room and path, right?
yeah. So Dr. Husaini was aware that we brought our friendly pathologist and our friendly radiologist to kind of help us down the line, and kind of rounding out other causes of the pericarditis that we want to send for. We do have, our room section. So is there maybe some
Yes,
direction
let's do
you
that.
want to travel to?
I feel like
Okay.
every time I pay and order room stuff, it's one of those like, I don't know what to do with this. But I think we have a room panel. So I mean, I guess the main things are like, is this, oh my God, this is hard, man. Because I feel like the hard thing is in this setting, do we think this was a rheumatologic etiology at the start for all three recurrences, or is something specific about this recurrence that's more rheumatologic related with that recent prednisone dose?
Sure.
And I don't know how to think about that exactly. And I don't know, like, because I think when I ordered my labs at this point, like room labs, it's like, it's also about not just what they are, but how do you interpret them? And this is again, which is I call my friendly rheumatologist asks. And so I'm going to presume I had a medical student or someone else to teach me these things.
So I'll give you,
help interpret them.
I'll give you another choice that's going to
Okay.
make your life much easier probably. So pretty early on, you probably would have sent for more advanced imaging right away. So we're kind of like blinding you from like a huge piece of the puzzle.
Okay.
So maybe before we move down to the room and pathology territory, how about we do maybe get some more imaging? And that's not what I meant to click. Okay. All right, so here with us, we have Dr. Ryan Short. So he's with our diagnostic radiology division, and he specializes in cardiothoracic imaging. So thank you so much.
All right, so yeah, starting out here, we have a few slices from axial CT with contrast. So I think as you probably saw on the chest radiograph there, you see bilateral pleural effusions. Let's see, and so so the effusion on the, oh yeah, this guy. Okay, so there's your right-sided effusion, your left-sided effusion. And then a very abnormal looking heart, right? So we see, the pericardium kind of going all the way out, far to the right and to the left here. There's some loculated pericardial fluid here. And then other areas in the pericardial space just kind of look like enhancing soft tissue. So you can see that coming down on these axial slices here. A lot of, intermediate attenuation, enhancing pericardial soft tissue, not as much fluid, a little bit of the kind of loculated fluid there. So I think, the differential at that time would be pretty broad. Could be infectious, things like tuberculous pericarditis or fungal pericarditis would be on the differential. And then neoplastic processes, of course, would be kind of the second big thing there, whether it's metastatic from somewhere else versus lymphoma that's kind of pericardial primary or other kind of primary pericardial processes. Notably, I would say there's none of that kind of nodular soft tissue in the pleural space. So where we're seeing that nodular soft tissue in the pericardium, we're not seeing that in the pleural space. So I think the patient went on to a PET CT. PET CT shows a lot of, all that area of soft tissue in the pericardial space. Shows a lot of FDG uptake. There were also some, low right paratracheal and prevascular lymph nodes that were also, FDG avid. Honestly, probably doesn't help to narrow the differential too terribly much. Like whatever was going on there was probably going to be FDG avid. Might give you a better target for, what to biopsy. And then ultimately went on to a cardiac MRI. So we're seeing 3-chamber cardiac MRI here, SSFP, Again, it's almost less impressive on the cardiac MRI because the myocardium, you know, this is the right ventricular wall, left ventricular wall. The myocardium is kind of the same signal intensity as that pericardial soft tissue that we've already seen before. The one thing, you know, to look for constrictive pericarditis on cardiac MRI, we like to do, you know, real-time cine images where the patient, you know, sniffs or takes a big inhalation so we can see more blood flowing into that right side and see if the septum bounces. You can hallucinate a little bit of a septal bounce here. Unfortunately, they did not do the kind of real-time cine images on this person. And again, a kind of a poor four-chamber cardiac MRI here. We see that loculated pericardial effusion to the right, like we saw on the CT. We see more of that loculated fluid out to the left, and then just extensive, you know, soft tissue as we've seen before. And again, the septum isn't moving a little bit funny. Is there kind of an early diastolic septal bounce? It's kind of a tough call in this instance. And then kind of putting it all together here, the CT, MRI, kind of T2 signal, and then the late gadolinium enhanced MRI images here. And again, you can see that soft tissue that we thought was enhancing based off the CT. You can see here on the LGE images that it is enhancing. This is kind of some artifact from epicardial fat there. But again, kind of to summarize, a large, you know, loculated pericardial effusion with extensive soft tissue thickening and kind of the differential as discussed.
Perfect. Thank you. So some follow-up thoughts that I have for now is that thinking again about the bilateral effusions, I'm thinking, is this all secondary to what's going on in the pericardium and vice versa? And I guess with a smoking history, it's in his 40s, started when he was a teenager, 20s, and we said there's no weight loss, other constitutional symptoms, right?
Mm-hmm.
So then we mentioned like a possible paraneoplastic syndrome, which I think is the only thing we haven't mentioned yet. So I'm still thinking about that room stuff. That's one of those things where I just kind of want to see what's going on. But
Yeah, absolutely. So we will, oh, sorry. Okay, so we'll take us back. Room wise, so we did send the full panel and we did consult room because we also weren't sure what exactly to look for. And then the CRP ESR, like we mentioned, was elevated, but otherwise, like this full extensive panel was sent and it was negative.
He doesn't have amyloids. It's good. Okay.
Not
Someone was guessing amyloid. I was like, it's going to be amyloid. I know it.
Okay.
And so at this point, it sounds like he's symptomatic. He has imaging findings that are concerning. This is, I think, where it's calling their friendly surgeon to try to get a biopsy and see what's going on. Here's probably the next best step. So we have another guest speaker that's just anxiously waiting to talk to us.
Okay. So we'll transition to our pathology section. So we have Dr. Alex Wine with us. Did his residency here and then is now a postdoc research fellow doing lung transplant, and then has a clinical focus on cardiothoracic pathology and kind of research in lung transplant. And if I'm remembering correctly, you actually were the one who saw this patient's actual slides and actually helped us diagnose him. So the pathology will reveal a lot before we before we get a full reveal. Is there kind of one direction that you're leaning towards?
I mean, clinically, effusive constrictive pericarditis still makes sense. Why? I remember there's like a Cleveland Clinic study looking at the incidence of all these things, but my mind is blanking completely on what the etiologies were. And so I'm glad that you were here. So please educate us.
Wonderful. Thank you. So hi, everyone. I'm Alex. We got a pericardial biopsy. I think it was actually called a subxiphoid lymph node. And so this is what we got. This is the entirety of the tissue. You have a nice piece of cartilage here and then some other stuff in these other two cores. Any thoughts so far?
I see colors. I see cellularity. I remember that.
Yeah, so we can zoom in.
Okay.
The microscope goes beyond 2x. So this is zooming in on one of the areas of pink and purple. And what you see here is a cellular process, kind of relatively low-grade cytology, not a lot of nuclear pleomorphism, not a lot of enlarged cells, kind of growing in a papillary to micropapillary pattern. Anyone remember medical school?
Are these eosinophils?
There's no eosinophils.
Okay, no,
here.
I'm done. I'm done, yeah.
And then just another area kind of showing the same thing. You have maybe a little bit of like a glandular structure here, and then some micropapillary growth kind of lining these spaces. And once again, this kind of collagenous stroma. So,
Oh, yeah. You know
what
what?
was that? It's on the differential, I guess.
Yeah,
What's everyone thinking?
I'm gonna say I have zero idea
Okay.
and some multiple choice. So, I mean, the main thing is the cellularity makes me think of malignancy, right?
Yes.
So I think the main thing is that we're thinking is this inflammatory rheumatologic, and a lot of our serum studies and everything else just weren't that consistent with it. In what specifically within oncologic process, I have zero idea.
Okay, well, I'll help you out.
Okay.
The
Yeah.
two leading things here, based on the architecture, the cytology would be lung adenocarcinoma or mesothelioma. You get some of these hilar lung adenocarcinomas
Okay.
that certainly can grow into the pericardium. And the mesothelioma, anywhere there's mesothelium, you can get a mesothelioma. Less likely would be a thymic adenocarcinoma. They are quite rare. And then a lung carcinoid tumor wouldn't usually grow like this, but the cytology is actually okay for a carcinoid. And one thing that we never want to forget is metastatic melanoma. I've had multiple times where, it's thought it was a small cell and gets the biopsy, it turns out melanoma. And then the clinical team asks the patients, oh yeah, have you ever had a mole taken off? And they say, oh yeah, 20 years ago, I had one on my leg. I don't know. The primaries can also regress with metastatic melanoma, and it's one that can come back 20, 30, 40 years later. So this is our differential at pathology. We're just going to look at the two leading diagnoses. And for this, we do our immunohistochemical workup. So the markers that were ordered for lung adenocarcinoma would be a TTF1, that's thyroid transcription factor 1. For some reason, it's also in the lung. And cytokeratin 7, mesothelioma has a couple cytokeratins, and then podoplanin is a more specific marker. And then because we're lung pathologists, we have to look for squamous cell carcinoma too. And so here's our staining results. It is diffusely cytokeratin 7 positive, little bit of cytokeratin 5/6. It has podoplanin and it is negative for TTF1 and P40. So putting that all together, do you want to say it?
Can you go back two slides? So mesothelioma sounds like the answer.
Yes. So this was a pericardial epithelioid mesothelioma with a micropapillary architecture. Our reporting on mesothelioma has gotten a little more descriptive over the past several years as histologic patterns and other things have been found to correlate with prognosis. So this is from a paper released last year from the mesothelioma consensus working group. And this is the broad histologic spectrum of what you can see in mesothelioma. So this would be a papillary mesothelioma. You actually have papillary cores with blood vessels. This is micropapillary, like what our patient had. This is a recently described adenomatoid variant. You can have solid. This is a desmoplastic mesothelioma. And so this just honestly looks a lot like a pleural plaque. It's really easy to miss this because the cells are actually very tiny. So, and like here you can easily see the mesothelial cells. Here it's all these little dots, and it has to do with the architecture and disorganization that separates a pleural plaque from a true mesothelioma. And then this is a transitional. So what you want is, in a resection, we have to report by percentages, but the things that matter, any micropapillary or at least 50% solid is a bad predictive prognostic factor. Myxoid stromal features have favorable prognosis. Rhabdoid cytologic features are unfavorable, and pleomorphic epithelioid mesotheliomas behave like sarcomatoid mesotheliomas. And the recommended workup for these is here. So we look at them We just look at it and see if it looks benign or malignant, and that's a good start. That's the way, we've been doing pathology forever. But now we have a lot more testing where there's actually gene alterations we can specifically test for that don't help with mesothelioma versus other diseases, but do help with mesothelial hyperplasia versus a malignant process. And so if there are any questions about the path portion, I'm happy to answer them, but that's all I really have to say.
Thank you.
Okay. So we've been on quite a journey together. Dr. Husaini, thank you so much for helping kind of go through this case and kind of giving us all your thoughts and leading us to our endpoint here. Any other kind of thoughts that you have now that we have revealed many
I
things?
am so glad I do not take care of patients alone. So that is definitely my main thought.
Okay, awesome. Well, there we have it. Yeah. Thank you so much. And then just like really quick hospital course for him. A lot of the people that actually took care of this patient are in this room, including myself. So huge thank you to everyone. So we did kind of establish this man with the recurrent history episodes of the pericarditis, and then came to find after this hospitalization and kind of this workup with the cardiac MRI, PET, and then the biopsy that it unfortunately was mesothelioma. And then based on the PET, it was determined to be metastatic. And oncology was kind of later involved, and he was initiated on inpatient chemotherapy. Unfortunately, due to like the severity of the disease, the goals were palliative rather than curative. And then we had different services involved, including CT surgery at one point and thoracic. And then the only intervention he was really eligible for was like a catheter to help with his management of the pleural effusion. And then he did unfortunately decline over several weeks, was in and out of hospitals kind of within that time period, and then eventually transitioned to hospice, I want to say 2 months after he was here at Barnes. So. And then we're at time now, but if you want to learn more about effusive constrictive pericarditis, come find me after. Okay, and then thank you so much, Dr. Husaini, and thank you so much especially to Dr. Mendoza, who's here, Daniel Huang, who's one of the other CARDS fellows, my co-chiefs, Edward and David, and then Taylor, Kiana, and Waleed, who helped directly take care of this patient. So thank you all so much. That was, no, you did so good. That was just like,
It's being nice. And then